Welcome to the OncLive Peer Exchange editorial video series, Clinical Developments in the Management of Renal Cell Carcinoma. I'm Dr. Daniel George, Director of Genitourinary Oncology at the Duke Cancer Institute. Today's panel discussion will focus on recent research and clinical developments in the management of renal cell carcinoma. This and other peer exchange videos can all be found on onclive.com. I have the privilege today of moderating a panel of leading experts and frontline practitioners. Our discussion will address a range of relevant clinical issues and challenges, including new data from major trials in renal cell carcinoma. We'll also discuss special issues, such as where we are, what we currently know about sequencing of therapies, and about adjuvant therapies and new emerging therapies. To offer their expert analysis, I'm joined today by my panelists. Dr. Robert Figlin, Professor of Medicine and Biomedical Sciences and Chief of the Division of Hematology Oncology at Cedars-Sinai's Comprehensive Cancer Center in Los Angeles. Dr. Thomas Hutson, Director of Genitourinary Oncology at the Texas Oncology and Professor of Medicine at Texas A&M Health Science Center in Dallas. Dr. Eric Jonasch, Associate Professor of Medicine from the University of Texas MD Anderson Cancer Center. And Dr. Brian Rini, Professor of Medicine at the Cleveland Clinic Lerner College of Medicine of Case Western Reserve University. Okay, so let's get started. Let's start a discussion today with one of the most important points in terms of late-stage trial results and some of the findings that have been coming out of these frontline studies. I think it's one of our most important areas right now in renal cell carcinoma, and we have two recent frontline studies with tyrosine kinase inhibitors that are really comparing two drugs to each other, the COMPARZ and the Pisces trials. They produced frontline study in comparison of pazopanib versus sunitinib, looking at progression-free survival and overall survival. Bob, if I can start with you, could you describe these two studies for us, kind of how they're different, how they complement each other, and what we can conclude from the results?
Thanks, Dan. The COMPARZ trial is a trial that's really the first of its kind, a comparison of two active, high-level evidence agents in previously untreated patients with metastatic kidney cancer. The COMPARZ trial was comparing sunitinib to pazopanib. It's what's called a non-inferiority trial. And what that means is that they're trying to demonstrate whether the two are equal in their ability to deliver care to the frontline kidney cancer patient. It was in over 1,000 patients with advanced or metastatic clear cell renal cell carcinoma, randomized to standard dosing, 800 milligrams a day of pazopanib or 50 milligrams a day, 4 weeks on, 2 weeks off of sunitinib. The bottom line results were relatively straightforward. Progression-free survival of pazopanib was non-inferior to sunitinib based upon over 630 events. What were the numbers? 8.4 months for pazopanib, 9.5 months for sunitinib, with a hazard ratio of 1.04, non-inferior. Overall median survival, 28.4 months for pazopanib, 29.3 months for sunitinib, a hazard ratio of 0.91. So what can the practitioner take away from this? The practitioner can take away from this comfort in knowing that if they're using either sunitinib or pazopanib in the frontline patient with previously untreated metastatic disease, they're delivering high-quality care. That's a little bit different than the Pisces trial. The Pisces trial...
Bob, if I could stop you right there, because I want to have a little bit of a discussion about
Sure.
that data. And I also want to bring up toxicity, because I think that's one of the other things we're learning when we're doing these kind of comparative studies of one TKI to another. You know, on paper, a lot of these things look the same in terms of their toxicity profiles. Can we glean any differences between the toxicity of these studies?
Yeah, so the good news and the bad news is yes and no. The problem with the COMPARZ trial is that its secondary endpoints were really toxicity evaluations. The primary endpoints were really progression-free survival. So what you can start to glean is you can, as one would expect, you see a bit of a difference in the toxicity profiles of the two drugs. Sunitinib causes more toxicity in relationship to hand-foot syndrome. Pazopanib causes less toxicity in that sphere. When they looked at 11 parameters, or something around that, pazopanib was a better tolerated drug in terms of the common toxicities that we think about when delivering a TKI in the frontline setting. My caveat to that is the following, and we'll have a bit of a discussion around that. The challenge was when you get to do the toxicity evaluation. So we know that pazopanib is continuous dosing, daily treatment. Sunitinib is 4 weeks on, 2 weeks off. One could imagine that the trial in its design had to pick a time point to ask and answer the question of a toxicity evaluation. And in fact, they did that. So some of the criticism in the trial has been in that choice of date. For example, they chose an every 4-week toxicity assessment. And for the pazopanib arm, we think that's appropriate because it's continuing dosing. But for those of us that use sunitinib, we recognize that treatment is 4 weeks of treatment, 2 weeks of rest, and that oftentimes the recovery from toxicity occurs during the 2 weeks of rest. So although I wish it were an apples to apples comparison, it wasn't.
It wasn't, yeah. Brian, what do you think?
Yeah, I agree with that assessment. I mean, I think the overall assessment is that they're both active drugs, right? They're both non-curative, but clearly active, provide some level of disease control. The overall survivals being almost 2.5 years is the longest really that's been reported. That's the good news for kidney cancer patients, is that their survival is at least double what it was in the pure cytokine era. I agree also in terms of the timing of assessments. I think it was probably biased against sunitinib based on the timing of quality of life, and also the timing of scans was after 2 weeks off. And we know that tumor can regrow in that 2 weeks. So when we see patients, we always try to time their scans at the end of the 4 weeks of dosing for just that reason. So we're not misled that the drug isn't still having an effect when in fact it was really just a result of a break. So again, that's just sort of the way the drugs are given. And again, at the end of the day, I think the overall assessment is that both drugs have a role in the treatment of kidney cancer. It's probably as important for the practitioner to learn how to give one of the drugs very well than to necessarily worry about which one they're giving, because there are nuances to each. There is a learning curve in terms of giving these drugs and handling side effects, et cetera.
Right. Tom, you know, there are a lot of dose modifications, interruptions, dose reductions in both arms of this study. How does that relate to your practice and how you use these drugs, and how much of a factor is that in the effectiveness of these drugs?
Oh, I think, you know, the studies, Dan, to date have shown us that dose intensity matters. Delivering the highest amount of dose to a patient is going to result in the greatest efficacy. But we also need to realize that we have patients here, they're real people that have to have a quality of life too. And so it's always a balancing act as a clinician, maintaining dose intensity and balancing quality of life. So I think, you know, what Bob said with the trial, I agree with, that the trial did show us that we have an equal drug, at least in efficacy parameters within the confines of the trial, but also a drug that seems to be relatively well tolerated. And I think you, as a clinician, just need to get comfortable using one of the drugs. That's going to give you the best opportunity to understand the drug, to be able to make dose modifications, to be able to handle the toxicity of it. And I also want to remind us that we need to commend the people who funded it. It was a pharma-funded trial because they conducted the largest trial to date in kidney cancer, and it was a head-on trial. Even though it has faults with it, it's a non-inferiority study, et cetera, but it was the first time we took two powerful leading drugs and actually studied them in a head-to-head fashion.
And I think that's a good point. I mean, this is the data we need to know. I mean, we need to know how these drugs look in exactly the same populations, not comparing always one study's results to another study's results. But Eric, does this get us